We have a new guest in the studio. His name is Dr. Kanyenje Gakombe. He is the chairman of the Kenya Healthcare Federation. He'll tell us all about that. He's also an investor in the private healthcare sector. We are talking about universal health coverage. It's Health Fridays, like we said. Every Friday we'll have a conversation about healthcare in the country. Rolling out and upscaling of the universal health coverage countrywide and the role that the private sector has to play in this. Dr. Gakombe, thank you very much for joining us. Welcome to Kenya's biggest conversation.
Thank you for having me.
It is an honor to have you there. That is the hot seat. I'm saying it's an honor because, guys, let me now tell you the story he even doesn't know. In the first half of the 90s, I went to a certain high school on Thika Road. And there, during break time, you'd go and buy a loaf of bread. When you go to buy this loaf of bread...
Was it the sliced variety or the unsliced variety?
The unsliced variety of the loaf of bread.
And it was cut into how many pieces? 3 or 4?
It has to be cut into 4 pieces. Okay. So they become what?
Chunks.
Quarters. Okay?
Bread chunks.
Those quarters, a quarter of a loaf of bread in Mangu High School, up to date, is called a kanyaks. Kanyaks. The man who's sitting with us here is called Dr. Kanyenje. The origin of Kanyaks
is here.
Yes.
That's a story we need to hear. That's a story we need to hear.
Was an enterprising young man when he was in school, very many years before I joined. You can tell us about it. Dr. Kanyenje, it's good to have you on the show.
Thank you very much.
You started your enterprising journey very early.
I had to.
Had to?
Had to.
Why?
Necessity being the mother of invention. I had to because I wanted a lifestyle that my parents couldn't provide. So I had to raise money to fund it. See, I come from the village. And my dad was a junior civil servant with 13 kids to raise. And that meant pocket money was 20 bob a term. And 20 bob a term was not enough to allow me to attend every function that I wanted to attend in school, and there were many. I was also a scout, and the scouts had no money either. We wanted to do more than we could raise. So I started selling bread to raise money for me and for the scouts. Wow. And before then, we were growing beans in Mango to fund the scouts. And before then, I was raising goats and chicken in the village to supplement parental income. So from Form 5, I became independent of parental support. I've been looking after myself financially since. Yes.
Good journey.
Powerful. That's a very powerful story.
Oh, yes, it is. And, has a legacy.
Kanyaks.
Kanyaks. Yes. Up to date. Dr. Gakombe, you also have done quite a bit in terms of investing in healthcare. You can give us your bit of an introduction on that, the role that you play in provision of healthcare.
It actually goes back to Mangu High School.
Okay.
Because many Mangu students ended up being doctors, as did my classmates. And to make medical school a lot easier for us, we formed study group. It was the best study group in our class. It was fun, and we passed exams, which is not an easy thing to do in med school. But along the way and during commercial breaks, we'll discuss our future as doctors. What are we going to do? This was the 90s, structural adjustment programs, no jobs except for doctors, no medicines in hospitals, 2 patients to a bed. And clearly that's not the system we wanted to work in. And we had 2 choices: to fix the problem or to migrate to other countries where the infrastructure was better. And many of my classmates are actually in South Africa, in the UK, in the US. They moved out to go to places where they could practice medicine properly. I stayed. I was the lazier one. I stayed. And I started Metropolitan Hospital to fill the gap between Kenyatta and the leading private hospitals, the Aga Khans and Nairobi hospitals, in terms of quality and cost. The idea was to provide a hospital and hospitals where those who could not afford the leading private hospitals then would have an alternative without having to go and congest Kenyatta and be 2 to a bed. So that was a basic thinking behind Metropolitan. So we raised money from the public. Interns are not very well paid. I think the salary then was 12,000. No, 6. We went on strike. The pay increased to 12,000. Actually, the strike took 3 months. The recent one is not the record breaker. The only difference is ours was illegal.
Under the law.
This one was by a legal union. Ours was by an illegal union.
Because and not as highly publicized.
Unions were not legal then for healthcare workers. But to raise the money, I had worked in the stock exchange, so I knew how to raise money from the public by writing a prospectus. So we sold shares to 500 people, convinced them to build their own hospital. So the hospital I run actually doesn't belong to me. It belongs to a group of people. I'm the public face of it. It's owned by patients and their doctors. And we've been doing that since 1994. Yes.
It's very interesting because even as you paint that picture, Daktari, then I'm almost convinced that one of the ways in which we can solve or which the medical issues in the country can be solved then is through social welfare, or is through a collective coming together of practitioners, experience, expertise, and funding, putting it together to then solve the problem. Something that happened years ago seems to be the answer to some of the things that we are having now in terms of gaps in the health sector in the country.
You are right. And in actual fact, a lot of healthcare infrastructure was built that way. If you look at the Aga Khan Hospital, it was started as a community hospital. You know, a community that felt they had no healthcare infrastructure, they built their own. The same applies to Guru Nanak as does apply to the MP Shah Hospital and to the Nairobi Hospital. They were all community hospitals that eventually opened to everyone else. And across the world, most healthcare infrastructure hospitals were built by communities, either around a church or around a particular ethnic group or a racial group, but they were community owned. It's only in recent times across the world that you have profit-seeking hospitals, or what they call private for profit. For the longest time, healthcare provision infrastructure was community owned, church or community owned. We simply put a new twist to it and brought shareholders who would expect a return on their capital. And that has become a growing area of investment, and the fastest growing actually, because missionaries are no longer coming to put up healthcare infrastructure. And I dare say schools were also started the same way. The school we went to was started by missionaries. And many schools in many communities are built by the local community who feels Serikali is not around. So they get together and build the infrastructure to take care of their needs. So it's a fairly old concept. What we did was to do it in a different way.
Right.
Yes.
What role do you think then that model can play today? Because, I mean, there's so many things that are going on right now, healthcare-wise, right? There's so many balls that are up in the air. Universal health coverage being rolled out this year. The questions in terms of what the national insurance body then will or will not be able to do. And then we're looking at it as a responsibility solely of government to be able to sort out this issue. And is it now time for us to maybe really look at it and say it cannot be the sole responsibility of government to have this thing done in the manner in which it ought to be done?
That's a direction we have to go. There is no government which is wealthy enough globally to fully take care of the health needs, perhaps with the exception of Scandinavia. You know, the Norwegians are first world economy with oil as extra. They can afford purely tax-funded healthcare. The rest of the world, you need a combination. Even the UK is struggling with a purely tax-funded system. And actually, Kenya's initial healthcare system is like the UK one, tax-funded. But in a lot of countries, there was realization that tax money is not enough. Why? Healthcare technology has made many more things possible. You know, in the 1940s, if your heart was not working well, you are consigned to an early grave. If you got many diseases, you died. You know, many times healthcare doctors were part of our job was to prepare people for death because there was very little we could do. Surgery has only developed a lot from the 1950s onwards. So as technology evolves, as the ability to treat cancer increases, as the ability to keep people alive gets better, and coupled with aging populations, and in Africa, many more babies.
Yeah.
That means the money, the generation capacity of the country is not adequate to match the growing needs of the population. And the only solution is A, to find ways to raise more money. And that's what you're attempting to do by making NHIF a mandate. Two is to use the money that is available well, which is an area we need to work on a lot more. Because the fact of the matter is that the healthcare system globally is wasteful, and some are more wasteful than others. It's highly labor intensive, highly paper intensive, and there are many more things we can do.
Explain the wastefulness that you mentioned.
Right. The first one is what I call appropriate care. If you take, this is the circumcision season in certain communities. If you want pediatric surgeons to be the ones to do circumcision for boys, that's a waste. Those surgeons would be better employed doing much more serious surgical work. That is something to be done by doctors with 2-3 years experience. If you want obstetricians to do deliveries of women who have no complications, that means we are deploying far much more advanced capacity than we need. If you want nurses to make beds after training for 3.5 years, that costs. That's a job you can train somebody for 6 months to do. So it is structural wastefulness in terms of the way we are organized. And then you throw in the procurement chain. You throw in using expensive medicines when there are cheaper alternatives, you know, quality, generics. So there are many things to do to make the system more efficient. You know, the insurers call it fraud, waste, and abuse. We don't like, I'm a provider, we don't like the use of those terms. Some are simply structural problems that we need to look at and make sure that we are getting value for money. And in the public system, where people don't pay, it's grant funded. A missionary doctor once told me that in a public healthcare system, every extra patient is a nuisance. Since I'm already paid, whether anyone turns up or not,
Right.
then any person who
Mindset.
comes to queue is a nuisance. You know, and I had to go through a mind shift. I did my internship in Kenyatta. A good night is when nobody turned up. Yeah, no one, no patient. That's a good night. You know,
Yeah.
in a
Mindset.
private hospital, that's a very bad night, where no patient chooses to come to you because you're on your way to closing. So finding the right incentive system where we are incentivized to take care of those who need care without fraud, waste, and abuse is critical.
But you know,
Dr.
Derek, even
Gakombe.
no, please, go ahead.
Yeah, Doctor. Thanks, Dr. Gakombe. The challenges you're citing as we roll out the UHC.
Yes.
These sound like the issues that bedevil UHC that we need to deal with. In your view, are we dealing with this? Is UHC adequately dealing with the governance? Is it adequately dealing with the partnerships between the public and the private? And is it doing so in a way that also considers the social? Because not everybody can afford to go private. So is the governance being handled, and are these partnerships anticipated and being managed well as we roll out the UHC, in your view?
Not as well as they should. Actually, healthcare has always been a PPP. It's always been a private-public partnership. You know, today we are talking about PPPs in roads and other things. You know, the expressway is one. The fundamental fact is that healthcare has always been, you know, a three-way partnership: faith-based, state, and private for profit. And one of the most successful programs we've run in this country is called the Kenya Expanded Program for Immunization. It's been going on for a long time. And children can get vaccines in any facility. The only difference between public and private, that in the private sector, the vaccine is free. You charge for your labor.
Right.
So you are not expected to charge a lot. The same applies to HIV. We provide HIV care. The drugs are free. We only charge for dispensing and the labor for looking after the patients. So somebody pays 300 shillings for a HIV visit because the drugs are provided to us free. And the same thing for child immunization. The challenge comes when NHIF is confused for a parastatal. NHIF is not a parastatal. It's actually a trust. The money is ours. It sits with the Ministry of Health. But when you truly think about its foundational nature, NHIF ought to be a trust, like NSSF. And its only job should be to pay for its members.
Right.
You know, should not be bothered about whether counties are building hospitals or not. It should be saying we will pay for dialysis to those who provide dialysis of acceptable quality.
With the
And
money
the-
they have
our
given
members.
us.
and the money should follow the member. You know, so the rates are set, and you can then go to whichever facility that is giving you care. And the ones that are providing good quality care will be the ones that will grow. The ones that are not will take the road to an early grave. And there's something that came with devolution that we have not fully addressed. Because you see, the biggest function for a county, for a governor, is actually healthcare. It's not roads, it's not security. Those are national duties. The biggest job a governor should be doing is to provide healthcare to those who live in the county. However, there are no county boundaries. It's a river or a road or some plant on the road.
Or an imaginary line.
Yes. So that means that people from, and I like citing the example of Murang'a, because that's where I was born. Thika Hospital is in Kiambu County. But it's just across the border. The biggest users of that hospital are from Machakos and Murang'a. So we are basically consuming Kiambu healthcare dollars, you know, and leaving Mwangi wa Iria and Mutua to use their
Their
healthcare money
somewhere
for
else.
other things. It's only a matter of time before counties begin to say, come on, you don't belong here. Now, before we get, or they decide we'll not invest, we'll have a very poor quality hospital so that people don't come. Because now the more you invest to make Thika Hospital better, the more the tourists you attract all the way from Garissa and elsewhere, except that they're not paying medical tourists. So when we took the route to devolution, one of the things we should have done in healthcare is to separate paying and provision, so that the hospitals are being paid for the work they do, they can grow, they can keep their resources, the way Mangu High School collects fees and does not contribute any of those fees to Thika High School. It's our money, you know, and I served on the board for 20 years. We raised money and used it in Mangu. Murang'a Hospital should be able to raise money and use it to improve. Some of that money should come from the governor of Murang'a, and some of that money should come from residents of Nyeri who come and cross a road and they pay a fee. So we have, of necessity, to separate paying and provision. And the mandate does help us to do that. However, when we start looking at NHIF as a cash cow to fund county infrastructure, we forget that the member who put his or her money in NHIF was not paying, expecting to only be confined to a county hospital. because the county hospital we have already funded through taxes. That we are already entitled to go to through taxes.
Of course, you will say that because you're in the private sector. But let's let's get into that debate after this break. It's 8:30. Our guest this morning is Dr. Kanyenje Gakombe. He's the chairman of the Kenya Healthcare Federation. He'll tell us actually about the Kenya Healthcare Federation. Actually, do that before we take a break. Who is the Healthcare Federation?
The Kenya Healthcare Federation brings together all the players in the healthcare value chain, from manufacturers to providers. And I'm taking the two extremes. So anyone in that space joins the Kenya Healthcare Federation, either as an organization or as an association. And the idea behind it is that if you're going to achieve better value for money for the person accessing healthcare, then we have to work at making the entire value chain more effective and efficient.
So you're looking at the private sector. The private sector.
Private
of health.
sector.
Yeah.
But we do engage with government. To the Ministry of Health is our mother ministry. We engage with them so that policies, laws, regulations are enabling for both private and public providers.
Okay.
For example, faith-based providers, the only difference between them and a for-profit hospital is that they do not distribute a dividend. They still have to balance their books. They still have to be economically sustainable because there are no donations available to many of them today to maintain the infrastructure. So our problems are not different. And therefore, there are many things we can do to help the entire healthcare ecosystem become better.
Time for that break. It's 28 minutes to 9. We're live on KTN Home, SpiceFM, and online. We'll be back shortly.
This is the Situation Room.
Eric Latif, Nduoko, C.T. Muga, usual guests. Today we have a guest host, Wanjiru Gekonyo, from the Institute for Social Accountability. And our guest this hour, which is Healthy Fridays, is Dr. Kanyenje Gakombe. He's the chairman of the Kenya Healthcare Federation and also founder. And what are you now at Metropolitan Hospital?
Founder and CEO.
Founder and CEO at the Metropolitan. We're talking about the role of the private health sector in the provision of universal health coverage. We know it is now being upscaled nationwide. The president officiated that function. We've seen the re-engineering of NHIF. There's a new law that is soon, once regulations are gazetted, will make everybody be a mandatory contributor to NHIF. It'll have a lot more money. Dr. Kanyenje was saying, we need to understand what NHIF is. It's a trust and not a parastatal. Trust means that it's serving its members. So soon everybody will be a member, Dr. Gakombe. But then you're also saying that the NHIF money should not be looked at as this pot where people are contributing and then the government will use the money to start developing healthcare infrastructure in the country. The NHIF should be viewed as this money that is going to support its members. So money should follow member. As we were going to the break, I told you, this one, of course, you have to say this because you are in the private health sector. This is where you've been. If we say that, don't you think there's also some sense in saying at policy level, let us use this pool to also develop the public healthcare infrastructure?
Eric, before he answers, can I say something? Huh?
Say it.
The good doctor mentioned something about the nomadic nature of healthcare seekers, somebody moving from one county to the other. And as you were speaking, the thing that occurred to me is, if the money follows the healthcare seeker, it'll balance out. What it means is this. If you have ensured that your hospital has the services that people require, they'll be compensated for it because the NHIF will pay for the services that are required in that hospital. So it'll up the game. Now, if it therefore means that this particular healthcare seeker may want to go to a private hospital, it does the same thing. What it means is the citizenry are given the opportunity to seek care where they wish to seek care. But also, it also means that the support that is demonstrated in the money that NHIF pays is then also distributed in accordance with the healthcare seeker.
Yes.
So the PPP that he mentions becomes a reality, an even bigger reality.
Yes. The
what
issue, though,
happened-
we are saying the same thing, I think. But remember, there are three healthcare providers. There is the private for-profit, there is the missionary, and this is the religious-based, and then there's the public. Now, private for-profit is able to raise money from floating a bond or whatever. The religious one is able to raise money from community
Benefactors.
and the other benefactors. Public has a constrained pot.
Do they?
Yes.
How?
Taxes.
Budget, taxes, that's where the money comes from. Now, how do we raise the level of public?
Public
If-
has an advantage, Eric.
Yes.
Public tends to be nearer to the people. Now, the reason why people then migrate is because what they are supposed to have actually provided, they do not provide. Even this constrained budget we speak of doesn't do what it's supposed to do. So, what am I saying? I am thinking that the only way people are forced to up their game is when they realize that this very same money that they could have been receiving because they can't receive it is going elsewhere.
But the question becomes, Daktari, and I think it's a very useful conversation. If the money follows the user, as we stand right now, private hospitals will be at a higher level of performance, and that's where the users will prefer to go. So that means the money will continue to follow the well-endowed hospitals, maybe even the better managed hospitals. So can we not separate the governance issue, which must be dealt with, but also consider those users who can't contribute as much, who also need quality, who would get left if we allow the money to go into private? Because then inevitably it will be the higher contributors who will benefit more.
You know, even if these government hospitals end up collapsing, let them. You know why? How long are we going to put up with this nonsense where every so often you hear of money being injected? And by the way, this free medical care we talk about isn't free. People pay, okay? People pay for services within public hospitals. You're never really told where this money that people pay for go to. You're never shown anything that is done with this money. The collapsing of these hospitals will give us an opportunity to think rationally about how we manage our public hospitals. And perhaps the PPP that the good doctor is talking about can now be brought into the discussion of, okay, it's a public hospital, but how can we go about ensuring that this public hospital works well? So long as they are limping,
the private
yes,
sector into it.
yes, so long as they are limping along and pretending that they're providing service that they don't actually provide, this game will continue. So if it means they'll be starved of money and they collapse, let them.
What about the
Doctor.
majority who can't pay?
Yes,
The
the social
majority of
angle of this.
Kenyans cannot afford to pay for health, cannot contribute adequately to support healthcare services, cannot pay enough tax to support healthcare services.
Remember,
What
City,
happens
there's
to
going
them?
to be some 5 million people who are going to be funded, whose NHIF is going to be contributed by the rest of us
government.
taxpayers.
You said
Because
5
they can't-
million.
And then we are
Because they
saying that
can't
those
afford
ones,
it. Yes.
that money will go to Dr. Kanyenje.
You know, Eric, there's something that
Can we start with dialysis?
Yes.
yes,
Yes.
please.
Let's take a journey down memory lane. There was a time dialysis was only in Kenyatta National Hospital.
Yes.
And this is one of NHIF's greatest success stories. So anyone who needed dialysis either died because it wasn't available or had to find relatives and a place to stay in Kenyatta and start queuing at 3 a.m. to access dialysis. Then NHIF introduced a dialysis package. And the private sector, because it has a shorter reaction time, you don't need, the budgeting cycles are shorter, decision making is shorter. Dialysis units were put up in county hospitals, in faith-based hospitals, in private hospitals, even as private standalone dialysis units. And today, many Kenyans are being kept alive through dialysis as a way to get a kidney and a kidney transplant. There are many places they can go to access dialysis. Because when you're talking about healthcare, the first question is access. Is it available? Because you could have a medical card. If you remember that accident in Busia many years back that involved senior government officials, the AR cards,
the plane crash?
yes,
Yes.
the AR cards were useless out there
That
because you have a gold card for AR, but
no
Facility.
access.
no one even knows what it is out there to accept it. And even if they do, the infrastructure is not available to provide the care one needs. So the first issue is access. The second issue is affordability. The third issue is quality. Then there is equity, right? So dialysis is now available. The money is following the patients, and they move from public to private depending on the quality, perceived and actual, and accessibility, so that you're not traveling across counties. So we've done quite a bit, and we must celebrate what we've achieved with dialysis. Cancer care, chemotherapy. NHIF began to pay for chemotherapy, and there are now centers, both private and public, where you can go and get chemotherapy. So by the money following the member, the better providers, public or private, we must defocus on the ownership and focus on value. Because when you focus on who owns the facility, we miss the point. The point is the facility there, and is it affordable, and is it providing quality care? The largest private hospital in Kenya, one of the largest, is actually inside the Kenyatta National Hospital. We tend to forget, but Kenyatta has a private wing, and that private wing is bigger than Metropolitan. It's actually a private hospital within a public hospital. Many hospitals had what you used to call an amenity ward, where you paid to access, although it's in a public institution. And part of the idea was to subsidize the cost of care for those who could not afford it. So when we focus on the ownership of the infrastructure, we miss the fundamental point that the point should be on the healthcare consumer.
Right.
Yeah.
Are they getting access? Is it affordable? And NHIF will then pay. Let's say they pay, for example, 9,300 for a dialysis session.
Right.
In Metropolitan, in Kanyenje, wherever one goes. So
are we saying that's what the conversation ought to be? Because, I mean, over the last 3-4 weeks, that has been the argument between public and private, taking it to the doors of NHIF and saying, look, you're saying at public hospitals, pay 18,000 odd for the 3 sessions that you would need of dialysis in a week, for example, right? Yeah. Private hospitals are saying, absolutely not. We cannot afford to give this care for this amount. So are you saying then that essentially if you're going to say 18,700 shillings, whatever, it doesn't matter whether it is private, it doesn't matter whether it is public, pay that amount? Or should we now start looking at what's it going to cost to do it at the private level? And because we've already buffered the public sector, or should it just then be across board? If we can offer this kind of care at this cost, it shouldn't matter the cadre then of the medical facility.
What we should do is to look at the real cost of providing care. Labor, infrastructure, everything. And then say, for private, you are also getting compensated for infrastructure and labor. In the public sector, taxpayers have already paid for the infrastructure and the labor. So you get less. The alternative is we stop funding hospitals directly through grants and pay them for work done. And actually that's the simplest. In order to focus away from this whole argument of private or public, let us say, let Moranga Hospital earn its money by providing care. They are paid for every patient they treat. And they live or die on the basis of attracting patients. They'll now go out and say, we are very good people. We don't keep you waiting. Because in the absence of doing that, they'll cease to exist. Yeah. So, and
would that be the better way to go, Dr. Ari? Because as you say all these things, the number one, and you've insisted, the number one conversation is access.
Yes.
Now, access means investment.
Yes.
Public investment has been dwindling over time. And that's why the private has actually been rising. Now, how do we encourage and increase public investment into this?
But can I add, even before because now we were discussing it earlier, we've discussed it before. It's about priorities. Government invests in infrastructure all the time. But what infrastructure are they investing in? At what cost and what value? That is the crux of the problem. Because CDF has I think, is it now on 40 billion that goes towards the Constituency Development Fund. Then you have the government, the CS of Education, saying that they have appropriated money to build CBC classrooms.
Yep.
And you're saying, but you have the CDF. What does it do? And it's an infrastructure fund. So it's about priorities.
Dr. Let me ask this question. You talked about wastage.
Yes.
And I had never understood some of these things until I talked to somebody called who was by the title of health economist.
Yes.
And listen to those people. It was like waking up to a reality that has been around you all this time and you didn't even know how to compute it, how to look at it. But it also brought me to another reality that I had participated in because I'd seen it. It's called task shifting.
Mm-hmm. Yes.
See, one of the ways in which he talks about health professionals, the things that they do. In the work of care and treatment for people who had HIV, one of the things that was realized was precisely that. You don't need a doctor to form circumcision. And I saw the task shifting to somebody with a clinical background, a nurse, a clinical officer, performing circumcision and performing it well. Now, what am I saying? I'm saying the conversation is actually a lot richer than we sometimes make it. Because we've limited the discussion to them against us or us against them, meaning they're these private people. And yet the people that are being talked of are the same. It's Kenyans who...
It's the same patient.
Same. They're not different patients. And yet the honest conversation, as I look at it, there's enough money in healthcare for the private, for the faith-based organizations, and for the public. But we have to find a matrix that forces the public healthcare service to focus on service delivery as a point at which they can then benefit from all these resources that are actually available. Because they tend to be comfortable and lazy because there are certain things they are guaranteed. So they don't even need to raise the bar because they're a public hospital. But when they're forced to compete like other people, then, one, the patient benefits from that element of competition. And as a good doctor said, I liked it, the money follows the patient. So you, the healthcare provider, will want that patient to come to you so that their money can follow them.
Are you agreeing then with what the doctor was saying? Maybe one of the solutions or the best solutions would be stop giving grants to public hospitals.
I agree with him 100% because it's something, it works. You know this story.
The grant goes to a patient, Wanjiro.
I agree with that.
It's not to the
No,
person.
not to the institution.
When it comes to this facility, if Wanjiro today goes to this particular facility, the money that you pay there, including the money that is subsidized for your service that you get, will then be left in this hospital. They will improve their care.
However, all funding to the health sector, to healthcare, doesn't come from NHIF. That's one of the sources.
True.
The other one is coming from
Kenya,
government.
no, it's coming from the Kenyan taxpayer. Actually, it's all from the Kenyan taxpayers
Yes.
and donor grants. Government is spending 8% of the budget on healthcare. It's supposed to be at 15%. So yes, I agree. Possibly NHIF the money needs to follow the patient. But the other side of that is you need to support the sector, recognizing that there are some places that do not have the resource capability to provide that level of infrastructure. So one, we need more funding. We need to be intentional about the infrastructure and where it's needed. Alongside that, we need to pay attention to the governance, because a lot of these problems have to do with the rent seeking and the corruption. And then lastly, there is maybe some 10-15% of the population who do not seek medical care because they can't afford it. I don't know if this has changed, but there was the government public expenditure review of 2017 showed that there are Kenyans who just don't bother because it's too expensive.
Because they know they will not afford it anyway.
They will not afford it. Even these private solutions, they don't do it. So we have to consider those people who are still out, even after the money follows the patient. There are those sections, the extremely marginalized of our, population, who who needs affirmative action, who need to be protected.
that's where-
Dr. Now give us your thoughts on that.
The first thing I want to say is the biggest competitor to private hospitals is not public ones. It's actually public health. When you prevent disease, my entire COVID unit, 43 beds, is empty. And I'm not looking for patients to fill it. I'd rather it stays empty and we find another use for it. Why? Because our public health interventions have taken COVID down to a level where we do not need the infrastructure. When COVID was at the peak, Nairobi Hospital built a 150-person facility. Aga Khan expanded. We moved from 0 to 43 beds, moved from no ICU to an ICU. My point is, and we tend to forget, and I like what he said, we tend to forget that the first job of a healthcare system is prevention. There is no country on earth that is rich enough, that has enough capability to look after everybody who is, if we all fall sick at the same time. Nobody. You saw it in Italy, in Spain, in the US, one pandemic, COVID, and systems collapsed. So pillar number one, prevention. Accidents, food quality,
Waterborne.
alcohol abuse, drug abuse. A lot of focus should be there so that we reduce the number of people going to hospitals. The mistake we make is to think healthcare starts at the hospital gate. Healthcare starts in the community, what we call level 1. And a lot of intervention should be there by community health workers. That is where the counties should be investing. That's where the government should be investing in agriculture, in accident prevention, in regulating duty operators, because that means you reduce the number of people who need to go through the hospital gate. Because the moment you go to curative health, it is expensive the world over. So we must make sure the number reduces seriously. Number 2, we should not assume that Kenyans don't know. Kenyans go seeking healthcare across the world, right? And generally they are looking for where they will get good quality treatment affordably. When people say they are going to India, they say 2 things. 1, we are not happy with the quality here. And 2, we are not happy with the price here. So we, KHF, have to work with our members to address the traffic to India, because India, South Africa, and other countries are competitors. Right. Then 3, as long as many people are poor, there won't be enough money, right? Generally, when somebody gets a job, 2 things happen. 1, they become a taxpayer, and 2, the employer will probably cover them medically. So for every Kenyan who gets a job, there is more money for many things, including healthcare, and that person can now depend on themselves. So government, like a good parent, should be very busy graduating Kenyans from being dependents to being contributors to the Commonwealth. Because as long as people are poor, and I know this because during COVID, I had to take a vaccination camp to my village. Why? COVID vaccines were available in Moranga town, but the fare is 200. You go, you don't find the vaccine, you go again, you end up spending 1,000 bob to access COVID vaccination. So we had to take it to the community where they could walk. So some people don't access healthcare because the transport itself is beyond their budget. So community focus on economic growth, and then identifying those who cannot afford, and we fund them as a country. But instead of giving grants, we give them a card, and their money will follow,
the service that they get. Asante sana. Dr.
Yes.
Ari, 1 hour is a short time. You'll come again, we continue this conversation. Dr. Kanyenje Gakombe is the chairman of the Kenya Healthcare Federation, also founder and CEO of the Metropolitan Hospital in Nairobi. We've been talking about the role that the private sector has to play in the successful implementation of universal health coverage. Thank you very much, Doc, for coming. See you again soon.
Thank you for having me.